My name is Jennifer Peel, and I am the director of the University of Washington's Center for Mental Health Policy and the Law. I am delighted to moderate today's session in our webinar series on hot topics in mental health, civil commitment. Today's topic is policy perspectives on Washington's continuum of care for severe mental illness. And we are delighted to have our presenter, Senator Manka Dhingra, join us today. And I'll share a little bit more about her background and bio in coming slides. But first, I want to go over some logistics for today. So if you're not familiar, the Center for Mental Health Policy and Law is housed within the University of Washington's Department of Psychiatry and Behavioral Sciences within the UW School of Medicine. The center's mission is to address the most urgent issues arising at the interface of mental health and the law, really in order to help justice-involved people with mental illness lead full and productive lives. And you can learn more about our center and programming at the center website. This is the 7th talk in our series, today's talk on policy perspectives on Washington's continuum of care for severe mental illness. I do want to draw your attention to our next talk in June, which will be a panel discussion of all of the speakers that we have hosted in prior talks. About recordings and continuing education credits. So the recording and presentation slides will be made available on our website within about 1 week, and we will email attendees with the link. Continuing education is only available for attendees who attend the live Zoom session, not for those who watch the recording. Certificates of attendance will be available for attendees who indicate interest. You'll receive an email from the center with additional details. Regarding continuing medical education, it is available. If you are UW faculty and staff, you received an email from the center with instructions and will need to sign in via text by 2 p.m. For non-UW learners, we will track your attendance via Zoom. You do not need to log in or update your name on Zoom. The attendance is tracked with your unique Zoom link. Some disclosures. Today's speaker, Manka Dhingra, has no financial relationships with any ineligible company relevant to this presentation to disclose. And similarly, none of the planners have relevant financial relationships to disclose with any ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Questions. We welcome questions, and we'll try to reserve time at the end for a Q&A session. To submit a question, please click on the Q&A icon in Zoom. As a reminder, we will conclude with some Q&A, and we are banking all of the Q&A questions that we get from all of the series, and we hope to present many of the questions that we don't get a chance to talk through today at that last session in June. We'll also be asking for any additional questions that you may want us to present at that June session. Some final logistics. It's important to recognize that the opinions expressed herein are the views of the speakers and do not reflect an official position of the center or the university. No official support or endorsement of the opinions described in this presentation come from the center or the university, nor should it be intended or inferred. Automated captions are available, and in the meeting controller toolbars, you'll see the show captions icon. We do ask that you complete the evaluation pool at the end of the session, and a link will be presented then. It is my absolute delight to present our speaker today, Manka Dhingra. Senator Dhingra is a deputy major leader of the Washington State Senate. She brings 2 decades of experience as a prosecutor and behavioral health expert to her role as chair of the Senate Law and Justice Committee. During her time in the Senate, Senator Dhingra has chaired the Senate Behavioral Health Subcommittee and has helped pass legislation and funding to transform the Washington State behavioral health system, really reorienting it around prevention as well as improving crisis response. She is one of the state's key proponents of expanding the 988 Suicide and Crisis Lifeline and continues to strive to ensure Washingtonians with behavioral health needs get the treatment they need and deserve. As a senior deputy prosecuting attorney, she created and chaired the Therapeutic Alternative Unit, where she oversaw the Regional Mental Health Court and Regional Veterans Court, helped to develop the 40-hour crisis intervention training at the Criminal Justice Training Center, and trained law enforcement in de-escalation and alternatives to incarceration. There's so much more I could say about Senator Dhingra, but that's just a small reflection on all the great work that she's been doing. And I'm so delighted that she is with us today. I'll turn it over to you, Senator Dhingra.
Thank you so much, Dr. Peel. It is such an honor for me to be here with all of you and have this conversation on civil commitment. And I was saying there are very few people who love to talk about this topic, and I unfortunately love to talk about this topic. I think it's so critical that we make sure people get the services and support they need when they need it. And so that is the conversation in front of us here today. And I'll just say, when people say, what does the legislature do? People tend to think we do something in a vacuum. And I'm here to tell you it's not. What the legislature is, if we don't do things to the people, I really do want to make sure that people think of the legislature as a partner that ensures that our programs and services can be effective and helpful. And yes, it is about the money. And it is about our policy. And so what I'm really hoping to do with this conversation here today is make sure that people understand what the current laws are, what is working, what isn't, and why. And then really understanding the vision that the state has in terms of creating a continuum of care, especially for our crisis care, and then what we want to see happen with our 988 system, how we see the role of civil commitment, forensic services, and how they all frankly work together with the hope that we are still looking at early intervention. And so, what drives this work? And I will tell you that even though some people might think there isn't a vision for the state of Washington, there is. There are so many people who care so passionately about mental health. And we have to make sure that we do have our North Star. And access to treatment from the top of your head down to your toes, no matter where you live or what your financial situation is what drives a lot of us. Really that vision that we can have treatment on demand for everyone, regardless of where you live or what your financial situation is. There is something fundamentally wrong in a society where the largest mental health hospitals are our prisons and our jails. And we have to make sure that we put the experiences and needs of the people with behavioral health issues, their loved ones, first in all that we do. All of us know someone living with behavioral health issues. They're our neighbors, our friends, our family members, ourselves, and we must approach this as a health issue, not a criminal justice problem. And that means focusing on treatment and early intervention, getting people the help they need when they need it. And that is what this vision is really about, is that no matter where you live or what your financial situation is, you can access that treatment from the top of your head down to your toes. And over the last 8 years, people from all across the state have come together to make sure that they are transforming a behavioral health system. We are trying to build a comprehensive approach to behavioral health that does include a robust crisis response system, but also builds the tools to intervene before people have that crisis, really moving away from a reactive model of care by investing in diversion and intervention programs. And that means we do have to make progress in 3 very critical areas: crisis response, crisis prevention, and growing the behavioral health task force. All that also means that you have to take a look at healthcare parity. And we talk a lot about integration and healthcare parity. And I think most people will tell you that when it comes to how people experience integration and healthcare parity, that the user experience is not there. We still are siloed when it comes to physical health and mental health. And we have to make sure that we are leading our state in true integration and true mental health parity. And that does mean that we have to talk about cultural competency. We have to talk about how we can destigmatize mental health for everybody in our state. And so while we focus a lot on crisis, because frankly, I will tell you, it is very expensive for the state, while we are building up our continuum of care for crisis, that does mean you have to build up the early intervention, because the hope really is that we are reducing people coming into crisis because we are building up the early intervention. And so we are adding capacity for services across the entire behavioral health continuum. And what we're really talking about is a place to call, someone to come, and a safe place to be. You know, lots of people ask questions on how do we pass legislation? How do we get ideas, solutions in front of the legislature so they can take action on it? And I'll tell you that I actually love hearing from people who are doing the actual work, because they're the ones who know what works, where the holes are, and frankly, how to fix those holes. One of the other ways in which people really are successful in passing legislation is by creating task force. And the reason why those are very effective is because they make sure that you are getting stakeholders from every aspect of that work, forcing them to sit together, breaking up silos, and making sure that they're working together towards a solution. And one of the very successful ways in which we have been able to do this work is actually through the Children's Mental Health Work Group. This was created in 2016, and the work that has come out of this work group has been truly incredible and has really improved the manner in which we are trying to provide care for our children. So when we talk about early intervention, that's the hope that we will not have to have kids in civil commitment or adults in civil commitment or in a forensic work if we can make sure our children get the services and support they need, so that by the time they're 18, they are not going to need that crisis work. So here are some of the work that has come out of the Children's Mental Health Group. And it really is about making sure that families and our children have the services and the support they need. And a lot of it is also about removing red tape. There is some bureaucracy, but we really have to identify what are the reasons why people have these policies, and is there a need for them? And if not, then we have to make sure that we remove barriers to accessing care. The depression screening for new moms has really been incredible, really making sure that we are taking a look at postpartum depression. We all know that that has an incredible impact on children and families. And that does mean developing strategies for home visiting. We've seen that from other countries around the world, that it is very effective. And when strategies like this come out of a work group, they end up being a lot more effective than simply doing a bill and trying to create stakeholdering around that. I'll just mention a few other things that we're doing, and this is really about trying to get people so that by the time they become adults, they're not going to need the crisis services that our current adult population is using. The Children's Long-Term Inpatient Program is the most intensive inpatient psychiatric treatment available to Washington State residents ages 5 to 17. I am so very proud of the Bridge program that we have, and that is really about making sure that we provide transitional housing for behavioral health treatment. And this is something that is an issue, especially for our adults. Like, while we have pilot programs for our juveniles, this is something which I'm sure all of you who deal with adults in the civil commitment arena would love to have access to, is a transition step-down program for our inpatient population. So as they transition back into the community, there is that lower level of care that they can step into. And you know, a few years ago, when the 988 system, when the 988 line was going to become live in 2021, many of us really wanted to make sure that we took that opportunity to create a system that supports 988 in a holistic manner. Because it is not just about having a number, it is about what are the services we expect to provide with that number. What is the follow-up that we want to have happen with this number? And how do we envision services being provided to the person who's on the other side of this line? So in 2021, Representative Orwell and I, along with so many stakeholders from all across the state, really came together to try to develop a vision for the crisis number. It wasn't simply about having a number and have someone answer the call and try to de-escalate. It was really about that entire continuum of care. And this is where we talk about someone to call, someone to come, and a place to go. And you know, I'll share a story about 988 because I do a lot of work on a lot of really tough issues: tax policy, criminal justice reform, gender-based violence. But this bill was one of the toughest bills I have worked on. And the reason for that is because it really was about envisioning a new way of dealing with crisis in the state of Washington. And the first hearing that this bill had in the House, it didn't go so well. There were a lot of different people who had a lot of different ideas on what they wanted to see. And this bill appeared to be in a lot of problems in being able to pass that legislative session. And when it had the hearing in the Senate, I really felt like a bull in a china shop, because so many of us were so passionate about making sure that our state passed a holistic 988 bill that the message was extremely clear. Each and every one of us, regardless of the work that we're doing with individuals in the mental health field, knows that our state is not living up to its expectations, that there is a better way of doing the work that we're doing. And that is what the message was around the 988 bill, that regardless of the work you're doing, come together to work on the vision of how you would want your loved one to be taken care of when they were in a crisis. And let's try to build that system, regardless of the silos that currently exist. And I'm just so proud because when that bill passed, Rep. Orwell and I actually got an award from Mental Health America, and our 988 policy is the national model. And while these awards have our names on it, that is really not where the recognition belongs. It belongs to everyone who actually showed up to do this work with the willingness and the intent to do the best work they possibly can. And I truly do believe that that is why we have the 988 system that we currently do, because it is about the people who have the expertise, who rolled up their sleeves and decided to do this. So we, in order to help address crisis more effectively, we established and improved our 988 Suicide and Crisis Lifeline. This is the place to call. Clinicians are there to provide support if you or someone you know is experiencing thoughts of suicide or self-harm, dealing with emotional stress, depression, anxiety. I think everyone on this webinar should know that 988 can help. They support individuals 24 hours, 7 days a week, 365 days a year. And tragically, we know that 1 in 4 deadly police shootings are a result of officers responding to people in a behavioral health crisis. We all know that having a behavioral health crisis is not illegal. It is a cry for help, and it deserves an immediate response from appropriate medical services with coordination from law enforcement only when safety is an issue. And so what we have done in the state of Washington is actually have co-location between 911 and 988, because we do know that many of the 911 calls that are made are actually calls that are better addressed by behavioral health professionals. And so having a co-location between 911 and 988, we're actually seeing 911 calls that are getting a warm transfer to 988 so that they can be an appropriate response to the person in crisis. We absolutely have to make sure that when safety is an issue, our law enforcement partners are a good partner for us to go out on these calls. And as Dr. Peel mentioned in the introduction, prior to coming to the legislature, I was a senior deputy prosecuting attorney with King County. And in that role, I helped develop the 40-hour crisis intervention training for law enforcement. And that training is all about de-escalation and about really making sure that officers slow things down and take the time to assess and develop a plan when they recognize that someone is in a behavioral health crisis. And I'm just going to share a quick story with you all. I used to train officers for a short period in the 40-hour entire crisis training curriculum. And I knew that at the end of that week, that the following week, I'm going to get calls from officers who went through that training. And this one week, I get a call from an officer, and he just wanted to share with me that he was dispatched to to an elementary school because there was a guy with a knife, and the school was about to let out. And when the officer arrived at the scene, the training that he had received in de-escalation, slowing down, assessing what was happening, kicked in. And he very successfully was able to de-escalate the situation, remove the knife from this man's hand, and then transport him to the emergency room, all before the children were let out of school. Now, this is a story where all of us who do this work, that's how we expect things to go, that people are able to de-escalate individuals in crisis and get them the help that they need. But these are also stories that don't make the news because they're not sensationalized. And so making sure that we have the right partners when we're doing the 988 work, when we're doing the 911 work in crisis response is critical. And I tell you the story because we know that everyone who does work as first responders has a role to play in how they respond to a situation. And we really have to make sure that everyone involved in this work has the tools to address a situation successfully. So one of the other things that we did with someone to call, making sure we have that coordination with 911 when needed, is also really taking a look at the technology platform. We really wanted to make sure that we had an integrated technology platform so that when someone calls 988, the person responding to that call has the information they need to ensure that this person is successful. Now, this is something that needs a lot more work. We don't have a technology platforms up and running already, frankly, because the vision is really to make sure that we have electronic health records, to make sure we have a room where we can store mental health advanced directives. We want to make sure we can do bed tracking. We want to make sure that we can guarantee next day appointments. And that is the vision on what this integrated technology platform will look like in the future. But in Washington State, we also really want to make sure that the services we are providing are culturally responsive. And so I'm so proud of the fact that we are the first, until today, the only state that has a native and strong line to really make sure that we are providing culturally relevant services to our tribal members. I'm very proud of our youth line, which has call and texting, because all of us who are parents know that our youth simply don't pick up the phone to call. But they do like to make sure that they are texting. We also make sure we have a veterans line. We also make sure that we are paying a lot of attention to our rural communities versus our urban communities, and really being strategic on how we make sure everyone gets the services that they need and are in all in an attempt to make sure we are de-escalating and making sure we're alleviating the crisis instead of making it become a forensic issue or having law enforcement involved. I will say at this point in time that given what's happening at the federal level, a lot of our cultural competency programs are at risk. We're greatly concerned about what is going to happen with our Native and Strong line, with our Veterans line, our Youth line. And I just want people to know that we will be doing everything we can in the state of Washington to continue to provide cultural competency services for our population. The second part of the 988 continuum of care is also someone to come. We want to make sure that the response, if there is a response that is needed in person, is appropriate response. And that means making sure that our responders are safe, that the person who they're responding to is safe. And so really making sure we have a team that can meet the needs of all of these individuals. So I will say I'm really proud of the fact that in Washington, 94% of the calls were answered in state. And in many areas, in other states, that rate is as low as 57%. And so the fact that 97% of the calls can be responded to within state is really impressive when it comes to the work that we are doing. Someone to come. We have actually really making sure that we have rapid response teams that can respond to individuals. And so for anyone out there, we still have funding and grants that are available if you want to get a response team, to have an enhanced credentialing as a rapid response team and get dedicated funding in order to be part of the someone to come. The third component of the 988 crisis response is really a place to go. We want to make sure that there are options for people in the state of Washington if they need a place to go that is not the emergency room or our jails. And this is where many of us actually took a trip to Arizona to learn about what they're doing in their state in terms of crisis relief centers. And so we do have a few that are currently in the state of Washington. One is in Kirkland. And this is a new facility type, which is a no wrong door policy, which means law enforcement can come up and the crisis relief centers accepts the individual. So there is no medical clearance that's required. There's not a long list of exclusionary criteria, because what we have seen is that when you create more obstacles for people getting into this housing, law enforcement very well might take them to an ER or to the jail instead of trying to figure out whether they will be able to leave the person at a crisis facility. So the crisis relief centers were created in order to remove all such barriers and really truly be a barrier-free entry. We also expanded our crisis response systems a couple of years ago to have them that are just dedicated to our youth. I know we don't have one that's up and running in our state right now, but there are organizations that are interested in starting it. And so really making sure that as a legislature, we are creating the policies needed so that they can be implemented. And these are some of the issues that pop up all the time, right? We always want to find out, why is the policy not being implemented in the manner intended? I was really hoping that we would have a lot more crisis response centers now than we currently do. We have a few that are open. I know that the few that are planned, but there are others that are hesitating. And so some of the barriers to implementation really can be about, what is our funding model? What's the reimbursement rate? And this is why it's really important to have discussions like this to really understand what are some of the other barriers in implementing policies that have been passed by the legislature. So the funding mechanism for the crisis relief centers is absolutely something that we're continuing to work on and seeing how we can make better. One of the issues that has come up, of course, is what happens when someone comes to a crisis relief center and needs to be civilly committed. What is unique in our state is that our civil commitment petitions can only be done through DCR, designated crisis responders. This is different than other states where there's a whole host of individuals who actually can do civil commitment petitions. And so this is a topic that we're talking about for the future is this something that we want to expand or need to expand to allow people who do the work in crisis relief centers to actually be individuals who are authorized to do civil commitment petitions. So more on that. I would love to get your thoughts on that and in general on how do you control entry into the civil commitment field. And obviously we do want people to have more access to places where they can go. And this is where the technology with the data bed tracking is going to be helpful as well in the future. We're not there yet. The other thing that I also wanted to mention is, in Washington, there is that recognition that we cannot do a cookie cutter model for everyone all across the state. Even though when we're talking about crisis services, it is services that the state is responsible for. We actually passed a bill that requires our behavioral health organizations to actually provide regional crisis plans. And we really want to make sure that we are picking like the BHASOs to be the ones who develop a crisis response for each region, because it is imperative that the people doing this work actually know each other. Because we find that over and over again, when people work in their silos, they actually may not know what resources exist just down the street from them or the next town over. So having comprehensive regional plans for crisis response is going to ensure that people will do, oops, I just realized I went forward on the slide. People are getting a comprehensive plan for each region, because what might work in King County is not what is necessarily going to work in Kitsap County, and maybe it's not what is going to be right for Walla Walla. So requiring this is going to be helpful in terms of actually providing a strategy for the legislature on what needs to happen next. It will help us identify where someone might be doing an excellent job, and maybe it is something we want to replicate in other areas of the state, or really get us a good understanding of what services are missing in certain areas that we need to then make sure that we are providing incentives or providing resources to develop those in those areas. And talking more about a place to go, we know that in the state of Washington, we really don't have all the facilities that we need in order to provide care for individuals at all levels. A lot of the work that we have been doing is actually making sure that we have clubhouses all across the state. We have some in King County, and when we look at the entire state, we want to make sure that access to resources are available regardless of where you live. So as a state, we have actually been requiring that each region actually have a clubhouse model so that individuals have a place where they can go, where they can get the services and the support they need. We've done a lot of work around long-term inpatient beds, intensive behavioral health treatment beds. I am just so very proud of the UW Teaching Hospital that's open, having an integrated curriculum. It's very exciting that we have this teaching hospital that's also developing the next generation of providers, because we cannot have a conversation about how we provide crisis care without talking about who are the individuals who will be providing that care. We have done a lot in terms of crisis walk-in clinics, and the new forensic hospital, which is continuing to be built and should be ready in a few years. We've done a lot of work around recovery residences. And this goes back to that niche of transition services. What do we do with someone who's leaving inpatient services? Where do they go next? Because we don't want to have them coming back into the crisis system. And so really trying to figure out how we can do supportive housing, especially following inpatient treatment. I'm actually really proud of the work we've been doing with the Lake Burien residential treatment facilities that support our youth with complex needs and children with developmental disabilities and behavioral health challenges. And we know that we have so much more work that we need to do in terms of our capital investment. So going back to the services that we need even though we talk about a place to go, there are a lot of places in a continuum of care that we're missing. One of the big programs that we actually don't have in Washington that is very robust is assisted outpatient treatment. This is something that, the hope really is that people are able to access this prior to needing inpatient, or even when they're originally civilly committed for the 5 days, really making sure that instead of continuing with inpatient, we have assisted outpatient treatment as an option. This is where, bills have good ideas, people have good ideas, but the implementation isn't there. And so we've had the assisted outpatient treatment bill in our state for years now. But when you talk to people about it, this is not something people fully understand or are exposed to. King County is using it, but not in a very holistic way. Clark County is using it, and I think Pierce County has a program, but assisted outpatient treatment is simply not working in the manner in which it was intended. And so this is where we need a lot more work to figure out what are the barriers to effectively using assisted outpatient treatment, and how can we make sure that we are making the necessary changes to make this an effective program. Because you have to make sure that you have access to services during the entire continuum of care. And this is where the Involuntary Treatment Act comes in. We had done a big rewrite to our ITA bill a few years ago. This was my legislation, where originally we used to do 72-hour holds, 3 days, and we extended that to 5 days. And the hope really around that was that the 5 days would give our treatment providers, our hospitals, sufficient time to make very clear diagnoses and set up outpatient care, with the hope that the 5 days would provide more stability and that people can maybe go out and assisted outpatient treatment or partial hospitalization and not need the long-term inpatient care. This is, again, something that is not working out exactly as intended, and there's going to be a lot more work done in the future and trying to figure out how we can improve our Involuntary Treatment Act. This session, the governor signed a bill that created a task force to take a look at ITA and come up with changes, recommendations to the legislature on how we can improve access to treatment for individuals. I'll tell you a short story on my work in ITA. As I mentioned, I was a senior deputy prosecuting attorney for 20 years. And there's a case that had stayed with me and drives a lot of the work that I do. There was a young woman who was charged with assault in the 2nd degree. She had basically taken a knife and stabbed her boyfriend multiple times. And when she was in court, competency was raised, evaluation was ordered, she was found not competent, and then she went for restoration services to Western State Hospital for 90 days. And I remember when she came back, she was competent. And after the court found her competent, she decided to make a statement. And she said that for years, she used to see snakes coming out of different places in a room, from power sockets, from the ceiling. And she said she never understood why no one else reacted to them the manner in which she was reacting to them. And for years, she lived in our world surrounded by snakes. And so when she was stabbing her boyfriend, she was actually stabbing the snakes that were crawling over his body. And she looked at the prosecutor, the defense, the judge, and she said, "How did you allow me to live like that for so many years? Why did I not have access to this treatment so I can understand that that is not the world that we live in, that there aren't snakes crawling all over the place where I am?" And I remember thinking about that a lot and just thinking, like, that is true. Why is it that she lived like that for so many years when she could have had access to the treatment that would stop those hallucinations? And so, when I take a look at forensic mental health, that is what I think about, because no one likes to be forcefully medicated. We want people to be able to make decisions about the healthcare, but there are times when we have to come in as a state and really provide that medication that's needed to stabilize individuals. And this is where the Mental Health Advance Directive comes in as well. We really, in the state, want to make sure that people are using the Mental Health Advance Directive as much as possible, that people feel empowered to come up with a treatment plan when they might not be stable, that has been directed by them. And this is, again, another policy that we have not been able to make as effective or as widely used as we would like, but really making sure that we are providing that agency to individuals to direct their healthcare needs when they might be less stable than they currently are. There's a lot more I can talk about removing barriers to substance use disorder treatment. This is absolutely an arena where we were hopeful that with integration and mental health parity, that people would be able to get access to substance use disorder treatment in a much more timely, effective way. And what we have found over and over again, that with medical necessity as a criteria, that this is actually a challenge. We have seen that the average length of stay is 11 days for inpatient treatment. And so we have passed bills that actually make sure that the original authorization for treatment guarantees at least 14 days of inpatient treatment, and then at least 7 more days until the next insurance review. So again, this is another arena where we need help from the practitioners to really help us understand what all is needed to ensure that we can provide treatment to individuals when they need it, instead of waiting for them to escalate and become worse. Of course, none of these policies can be implemented without the workforce. We really do need every single person who is doing the work that they're doing to have the resources they need to be successful. So we have been, as the state of Washington, working on actually improving and creating more credentialing for people in the workforce. We're very proud of the fact that we have a co-occurring disorder specialist, which is a new certified health professional. I cannot speak more highly of our peers and making sure that we have a pathway for peers to get more involved in providing care. It is an untapped resource that I fundamentally believe that our state needs to do a better job of providing more resources. And so I'm really proud that we do have certified peer specialists, and more on this work. We really want to make sure that they are part of the team at every level of care, especially when it comes to crisis care, as a place to call, even someone to come, making sure they're part of that outreach team, and really someone who helps with outreach efforts and connecting individuals to long-term treatment. I'm very proud of the work we've done in creating the behavioral health support specialist program that is evidence-based intervention that can be provided under the supervision of a licensed providers. And I'm excited for what that means, an expansion of that program. And then, the Mental Health Counselor Compact, really making sure that it is easier for people from other states to come and work in Washington. I was really proud of the bill in 2023 that provides occupational therapy services for people with behavioral health disorders. And I have to tell you, this is the bill which I was shocked that I had to run, because isn't that what integration was all about? Is that anyone who's doing this work should provide services and support so that people can stay out of crisis. But I had to run a bill to make sure that our occupational therapists can actually work with our mental health clients, because they are so critical in teaching basic activities of daily living, household skills, and managing acute symptoms. And this really makes the difference for individuals who can continue to stay in their homes versus needing to go to the emergency room. So we do need to expand occupational therapists as being part of the mental health team, because they can really make sure that people stay where they are instead of needing crisis care. So going back to the learning objectives we had, I am really hopeful that you got a better understanding of our state civil commitment laws, what is working, what isn't, and why. And, this is, I feel like I said a lot of what wasn't working. We do have assisted outpatient treatment, not working as we hope, but hoping to expand it. A civil commitment, we continue to do civil commitment. We have to take a look to see whether designated crisis responders are and should be the only ones who do this petition, or whether we should expand that. Taking a look at partial hospitalization, which we utilize for our youth. I would love to see partial hospitalization as an option for everyone, regardless of age. And then our forensic mental health system, really seeing how we can unclog that process and make sure that people are able to cycle through the system and be stable instead of doing the cycling with our criminal justice system. And with that, I am happy to take any questions. And thank you all so much for your attention.
Okay, Senator Dhingra, thank you so much for a very informative talk. It was so helpful to hear the vision of policymakers and some of the recent legislation and how that is actually impacting service delivery in our state. We already have, several questions coming in, and I encourage all of you who are participating today to please write in your questions. We're going to try to get through as many as we can, and we'll certainly bank all questions we don't get to in an effort to possibly present them at our June meeting. It looks like we have several questions related to kind of the policies and practice of policymaking in general, and then several questions related to substance. Senator Dhingra, you had mentioned early on that you appreciate hearing from clinicians and people in the field. For those who maybe don't have experience working with policymakers or are interested in getting involved in advocacy, how might you recommend that they, get involved in the process or initiate that?
Well, I think now is really the right time. We just finished session. We are a part-time legislature, which means we're only in session from January through March or January through April, depending on the session. And so this is the time to email your lawmakers if you have any suggestions or ideas. This is also the time where you can ask lawmakers to come and take a tour of your program. And this makes a big difference in understanding what is happening in Washington, what is working, what isn't. I put my email in chat for everybody. Feel free to reach out. And the story about that I talked about, the occupational therapist, that bill came about because DESC, Downtown Emergency Services, was giving me a tour of the new facility. And there was an occupational therapist there, and she identified herself, and she said she's very excited to do this work because she has never worked with mental health clients as part of a team before. And I asked her why, and she said that they were only able to bill for her services because the city of Seattle had given them some grant money to do so. And when you think about what do people need to maintain their housing, it is about the work that our occupational therapists do, like making sure that they are able to do basic necessities, that they are able to follow the rules of housing. And that's how that bill came about. It's because of that woman. And I was very excited about the bill, so I dropped the bill. And then the lobbyist called me and said, Senator, how come you didn't tell me about this bill? Because I had forgotten to tell the lobbyist, because it was a person doing the work who was so excited about the impact they were having. And DESC clearly said that if it wasn't for the skills that this individual was providing their clients, many times the clients would have either lost their housing or referred to an emergency room because they were unable to provide the care. So I tell this story as a way of saying that it really is about the work that people are doing directly. And if there are funding challenges, if you are doing the work because you got a special grant and you think it needs to go statewide, this is the time to reach out and let us know, because we want to make sure we're working on policies that are effective. I do want to give a caveat and say that this was an extremely tough legislative session, given our financial situation and given what's happening at the federal level. And so we know it takes money to run good programs, but we just have to be a little bit careful in making sure what we are doing given unlimited resources. But this is really, you guys know what the barriers are, and you guys know how to solve those barriers. So reach out.
Very helpful advice. It looks like there are several questions asking about data collection to see if any of these policies are in fact being productive and helpful. One question in particular asks about any data yet on kind of the warm handoffs between 911 and 988. How frequently is that being used and how effective is it?
Thank you. So we are not doing that all across the state. We started doing that at one of the call centers, just to make sure that we're doing it right, that it's working well. I haven't seen concrete data yet. They are collecting it, and we should be seeing what that looks like, but we are hearing that it is going really well, that 911 and 988 is really working well together. And I just want everyone to be very clear. This is not about making sure law enforcement is responding to calls. It's not 988 transferring to 911, but really what we are finding that there are a lot of people calling 911 when really it is that behavioral health support that they're looking for. And so more data on that, because we do like to be data-driven and evidence-based. And we'll be following up on seeing how that is going. But right now, what we are hearing from people is that it is something that's working well. Law enforcement is really liking it, and our 988 behavioral health clinicians are really liking the way it's working right now.
You mentioned several times in your talk the role of housing and how important that can be. There's a question here. Are there any specific plans at this point to create more mental health housing in our state?
You know, I wish we could create so much more mental health housing in our state. We do have a lot of facilities that are opening up. The thing with construction, especially if we're talking about inpatient facilities, it takes a few years for them for idea, funding, and execution. So we will be seeing new inpatient facilities opening up, but we also have to take a look at multifamily homes or other residential types where people can stay. And this is something we continue to work on with housing, with affordability, and we have to build capacity at all levels. We also have to make sure we have providers who are willing to do the work. And so many times, we talked recently about just detox facilities, why we don't have enough in the state of Washington. And it comes down to providers. Do we have providers who are willing and able to do this work? Do they have the ability to set up these facilities? Because we do have a lot of NIMBYism, where people are like, not in my backyard. And this is where really each and every one of us has to talk about stigma and destigmatizing mental health and substance use disorder, and really talking about how are we helping our neighbors. So we continue to try to get creative on when we're talking about housing. It is a problematic issue, and one that we really want more and more people to try to help us with solutions. I've spoken to so many ER doctors and people who work in emergency rooms, and so many of them will tell me, I wish I could write a prescription for housing. And I think many of our physicians are right. If they could write a prescription for housing and we had to fill that prescription, we would be looking at a different society. But I think we have to think of housing at that terms. It is as critical as providing that prescription for medication. So anyone with great ideas on what kind of housing, where, and who can provide it, I'm all ears.
Okay, a call to action for us all. Yeah. Here's a kind of a high level question. What challenges, Senator, have you faced when supporting behavioral health legislation?
I'll say behavioral health legislation is something that so many people are interested in. It's also a policy that is very, very nuanced. It is also policy that people have a lot of strong opinions on. And it is also policy that if you want to do right, costs a lot of money. And so a lot of the challenges to behavioral health policy is the cost of implementation. And this is what I tell people all the time. You can write great bills, and all you end up is with a good novel, unless you have funding for it and unless you have an implementation plan for it. And this is why we did the 988 bill in the manner in which we did it, because we really wanted to make sure we had that implementation plan, because we created a committee that works on implementation, which has subcommittees, that is very inclusive. And it has its own dedicated funding source, and that is the 40-cent telecom fee that everyone with a cell phone pays, the 40 cents. And so I want to thank each and every one of you for paying your 40 cents a month to help a 988 system. But the biggest barrier is funding, and then having an implementation plan that is workable. And people have strong feelings when it comes to civil commitment. And it is tough. right? Because you have to balance that individual liberty with forcing medication on someone. And so what I always like to say is, if you see someone having a heart attack on the street, what do? You call 911, you have the ambulance come, they stabilize the person, and then you talk about aftercare. You see someone actively psychotic on the street, and what do? People turn around and walk away. And so we really can't have parity if we are not treating the heart attack the same way as we're treating a psychotic episode. And I would love to get to the point that when you see someone who is actively psychotic or is experiencing psychosis, that they call and get the help they need and stabilize that individual. And until we get there, I don't think we are going to be able to provide everyone the treatment that they need and they deserve in a timely fashion. So that philosophy on who gets treatment how and the stigma are again some of the barriers to implementing behavioral health policy in this state.
I appreciate that in your talk, you mentioned the forensic system. There's a question here. How do you think we could make a smoother transition from the criminal to the civil system, and maybe divert people from the criminal system altogether?
And that is what our hope with 988 really was, is that, first of all, when people are in a crisis, who do they call? You see so many people calling 911 and then that person being taken to jail and being booked. And so that was the hope with where we have someone to call that is not law enforcement, the someone to come who isn't law enforcement, and a place to go, which isn't our jail. And so we're really hopeful that the 988 system, when robust and is able to fulfill all of these goals, will be basically the diversion that is needed for individuals away from our forensic system. We still do have a therapeutic courts. So we have our mental health courts. We have our other therapeutic options. We have recovery navigator programs. We have people in our jails who do forensic work. We have outpatient competency restoration programs, though they're not available in every county. We're really making sure that we are able to divert individuals from a forensic system, but then having a forensic system that is workable. And this is part of building the different facilities that we have with the UW Teaching Hospital, with the Olympic Hospital. There's a new facility opening up in Thurston County called Maple Lane, and then we have more facilities opening up in Clark County, with the hope that you can do that through the civil system, not the forensic system. Because it's, in order to shift everyone away from the forensic system, you got to have a robust civil commitment for system, assisted outpatient treatment, and lots of work to be done there. And then, of course, true diversion, where they don't have to go either to a hospital or a jail, but can get the resources they need out in the community.
Okay. Unfortunately, we are about out of time, but I think that was a nice way to wrap up some of the things you discussed. Senator Dhingra, we thank you so much for your participation and excellent talk today. We hope that individuals who were able to join us today will also be able to join us in June. So I do want to remind you that our next session will be on June the 10th, and it will be a panel discussion on civil commitment in the Hot Topics series, really reconvening the panelists from all of the sessions we've had before. And feel free to send us additional questions to pose at that panel. You can do so by the link that is identified here.
Thank you all so very much. It's been a real pleasure to be here.
Great. And we'd also love to get some feedback from any participant who wants to provide some feedback. We will be asking for some feedback on post-event surveys, and I think the survey just got posted. All right, everybody, have a wonderful afternoon. Thanks again, Senator Dhingra. We really appreciated the wonderful talk.